All right. Hello, everyone, and thank you for joining us for today's Provider Education Network webinar. November is National Diabetes Awareness Month, and in acknowledgement of that, today's webinar will focus on improving diabetes outcomes in Louisiana. My name is Marcy Hubbs, and I'm the Provider Education Network Manager for Well Ahead, Louisiana. I'm a registered dietitian and a certified diabetes educator, so I'm very happy to help facilitate today's webinar focused around diabetes improvement for our state. I also have my colleague, Rebecca Guidros, with me today to help facilitate this webinar. She's also a registered dietitian and serves as the Diabetes Prevention Manager with Well Ahead, Louisiana. So here's an outline of today's webinar. First, we'll review webinar objectives and give an overview of the National Diabetes Prevention Programs and Diabetes Self-Management Education and Support Programs. We'll then introduce today's panel members and begin our discussion with our panelists. We will reserve time for participant questions after we've completed our panel discussion. And lastly, we will share a list of resources related to diabetes prevention and management. So today's webinar is for both participants that may be new to diabetes programming and looking to establish a program, but also for participants that have an established program they'd like to improve. So our learning objectives today are, at the conclusion of the webinar, participants will understand when to refer to DSMES and National DPP. They'll understand the benefits of DSMES and National DPP participation. They'll understand the barriers and challenges of diabetes programming and learn tips to overcome these challenges. And we'll also be able to list resources available in assisting development and improvement of DSMES and National DPP. So let's glance at diabetes statistics for our states. Louisiana has the 9th highest diabetes rate in the nation. This affects 12.6% of our state's population. And here's a look at pre-diabetes in our state. According to the American Diabetes Association, 1.27 million people in Louisiana have pre-diabetes. That's enough to fill the Superdome 17 times. So what we know is pre-diabetes can increase our risk for not only developing type 2 diabetes, but also heart disease and stroke. And the CDC estimates that 15 to 30% of people with prediabetes will develop diabetes within 5 years. So knowing these statistics, we realize how imperative it is to improve access to and participation in ADA recognized, ADCES accredited DSMES services and CDC recognized national diabetes prevention programs. So today we'd like to show you the benefits of both of these programs, but also talk to certified lifestyle coaches and certified diabetes educators to hear some of the barriers they've had in programming and with participants and give their insights they have for overcoming these barriers to improve outcomes. Some good news is pre-diabetes can be reversed through lifestyle changes. So let's take a look at some specialized programs aimed at helping prevent diabetes. So Rebecca will now give us an overview of National Diabetes Prevention Programs. Thanks, Rebecca.
Awesome. Thank you, Marcy. So welcome, everyone. For y'all that are not familiar with the Diabetes Prevention Program, I know there's several people on here that probably very familiar with it, are actually going through maybe implementing a program or have already been implementing one for a while. But just to kind of get everybody up to speed on the program, it is the largest national effort to mobilize and bring evidence-based lifestyle change programs to communities across the country. The program was launched in 2010 through the Center for Disease Control and Prevention to address the increasing burden of prediabetes as well as type 2 diabetes. So of the core elements of the National Diabetes Prevention Program is its structured year-long lifestyle change program that's intended to target those at risk for developing type 2 diabetes. Participants are guided by a trained lifestyle coach in a community setting or an online setting, and the coaches can be any kind of health professional or non-licensed personnel, so a community health worker or just any layperson that is interested in teaching this class. A lot of times classes will be led by someone that actually participated in the class as well. So you'll see that a lot as well. The lifestyle coaches also use and follow a CDC approved curriculum to achieve key outcomes, which include increasing healthy eating, their physical activity, trying to lose between 5 to 7% body weight, and just making overall lasting changes within their lifestyle. The diabetes prevention program also includes, through the 12 months, it's 16 core sessions that are conducted weekly during the first phase. And then the second phase is a minimum of 6 follow-up sessions, and that's going to be those last 6 months of the program. The lifestyle change program also, again, can be delivered in person, distantly, or virtually, but a key feature of either approach is that it is group-led with support, peer-to-peer, support through each participant, and that's what really helps make it a very effective program. So next slide, Marcy. So let's talk a little bit about screening individuals that are at high risk. If someone has 3 or more of the listed factors on the screen, they're considered to be at risk for type 2 or likely to have prediabetes. So risk factors include being 40 years old or older, having high blood pressure, being male, a history of gestational diabetes, family history of diabetes, being physically inactive, or a BMI greater than 25. And so a best practice really for any clinician or anyone that is looking to implement the diabetes prevention program is to kind of ask these questions and do screenings on all non-diabetic patients that are 18 years and older, just to get an idea of their family history and ask those screening questions. And then I also want to just briefly share the eligibility requirements for enrolling into the diabetes prevention program. So to be eligible for referral to the CDC recognized lifestyle change program, participants must be at least 18 years and older. They must be overweight, so that's a body mass index of 25 or greater. For Asian, it's 23 or greater. They must not be pregnant, and then they cannot have any previous diagnosis of type 1 or type 2 diabetes. And then the last part is to either have a blood result with an A1C of 5.7 to 6.4, or a fasting glucose of 100 to 125, or that 2-hour plasma glucose of 140 to 199. However, if you don't have any access to get these blood results from your participants, you can just ask them of any previous clinical diagnosis of either one of those blood tests, or if they were gestational diabetic, or they could just even take the pre-diabetes risk test, which we'll share at the end of the presentation as well, and can send out, is the pre-diabetes risk test that is online through CDC and the American Medical Society. They have it online, and then there's also a PDF version, and then we also have a Well Ahead branded push card with those questions. Okay, next slide. Okay, so why would you want to start or refer to a program? So research shows that CDC recognized lifestyle change program participants who lose the 5 to 7% of their body weight and add the 150 minutes of exercise per week can cut their risk of developing type 2 diabetes by up to 58%. And then 71% for people that are over 60 years and older. Even a decade later, program participants were 1/3 less likely to develop type 2 diabetes than individuals who did not join a program. So this program can offer and lower a participant's risk for not only for developing type 2 diabetes, but for a heart attack, stroke, just improve overall health, increase energy, and even reverse a pre-diabetes diagnosis. So these lifestyle changes that are made very slowly and consistently can last a lifetime, improving overall quality of life, physically and mentally for those participants.
Thank you, Rebecca. So we've seen the statistics on diabetes prevalence and know that diabetes is linked to and leads to other serious chronic disease. So with the significant impact that it poses, offering effective diabetes education in the form of diabetes self-management education and support is a priority. So let's look at why having an accredited program is so important. An accredited or recognized DSMES is more effective because education and support is individualized for each patient to cater to their specific needs. And education is based on evidence-based guidelines and standards. The program is designed to empower patients to make behavioral changes through informed decision-making, self-care behaviors, and problem solving. And also to ensure sustainability of the education program, accredited recognized programs can be reimbursed. So when do you use a DSMES? So first of all, a patient must be referred to the DSMES program through the treating physician or a mid-level practitioner, but when? Of course, education is crucial when a patient is first diagnosed, but after this initial diagnosis, they can also be referred to the program at an annual assessment. So if at that annual assessment you see that there's further education, nutrition, or emotional needs, referral may be indicated. So a referral may also be indicated if new complicating factors arise. So this would be a new health condition or decreased coping skills. Oops, sorry. Lastly, a referral may also be indicated if there's a transition in care that affects their ability to self-manage their diabetes. So such transition would be like a change in living situation or their family or support structure. So what are the benefits of the DSMES? Well, considerable evidence has been given to show how DSMES participation provides positive impact. Some of the shown benefits are that it can lower A1C by as much as 1% in people with type 2 diabetes. And there are reduced health risks with this 1% decrease in A1C, including a 21% decrease in diabetes-related deaths, 14% decrease in heart attacks, and 37% decrease in microvascular complications. DSMES can also reduce diabetes distress, which is the emotional state where people experience stress, guilt, or denial from the burden of taking care of their diabetes or their diabetes management. And it also saves money by reducing hospital admissions, readmissions, and healthcare costs related to diabetes complications. Sorry. So that gives you an idea, a good overview of the programming that we'll be focusing on with our panelists. And today we have with us a group of panelists that currently work within national diabetes prevention programs or diabetes self-management education and support programs. They're here to share insight and give guidance based on their own experience. So please let me introduce our panelists today. We have with us Lindsay Barleycorn. She is a registered dietitian and certified diabetes educator with Our Lady of the Lake and the LSU Health System in Baton Rouge. Cindy Cuvion is a registered nurse and certified diabetes educator and lifestyle coach at MLK Health Center in Shreveport. We have Janet Minasani, is the executive director of MLK Health Center and Pharmacy in Shreveport. Alexis Motley is our registered dietitian and lifestyle coach with Healthy Lives, a Franciscan Missionaries Health System, which reaches statewide. And lastly, we have Candace Phillips. She's a registered dietitian and certified diabetes educator with Lolly Kemp Regional Medical Center in Independence, Louisiana. So thank you all so much for taking the time to join us today and share your experience and knowledge with our network. So we'll get started with first questions focused on diabetes prevention programs. So I'll be addressing these questions to our lifestyle coaches on the panel. So we'll get started with an overview of each of their programs. Alexis, would you mind getting us started with giving us an overview of your program?
No problem. Can everyone hear me?
You're good.
Okay, so hello everyone, I'm Alexis Motley and I work with the Franciscan Health System. Our department department is Healthy Lives. Our diabetes prevention program is called Stay Healthy. Our health system, it's located in different locations. Our ministries are located in Baton Rouge, Lafayette, Monroe, Bogalusa, and Jackson, Mississippi. The health system noticed that we had many team members with prediabetes. They were overweight or obese, and they wanted to offer a program that could help the team members decrease their chances of getting type 2 diabetes. We completed all of our necessary paperwork with the CDC in July, and we started our first cohort this August, so August 2020. Our current recognition status, we're pending. We offer our programs to team members and agencies contracted with Healthy Lives throughout the Franciscan ministry. Our first cohort is here in Baton Rouge, and we're projecting our next cohort to be in our Lafayette market and an external client here in Baton Rouge. Due to COVID-19, we're offering our classes virtually and in person. Our health coaches set up in-person classes for the team members who would like to be in the classroom setting, and we offer the same class at the same time virtually for those team members who do not feel comfortable. But things are changing with the COVID protocol, so we might have to go completely virtual very soon. Our first cohort has 10 team members participating. We have 2 lifestyle coaches working with this cohort. And Healthy Lives, we currently have approximately 15 lifestyle coaches on our staff. So that's the overview with our Stay Healthy Diabetes Prevention Program.
Great, Alexis, thank you. Janet, can you give us an overview of your program at MLK?
Sure. MLK Health Center and Pharmacy is a free clinic and free pharmacy located in Shreveport, Louisiana. We have a little bit of a different background than Alexis has. We started this in 2013, seeing the rising rates of diabetes in the state and pre-diabetes. And it was basically, we had a grant opportunity through Blue Cross Blue Shield to implement the program, get 4 lifestyle coaches trained through the DTAC Center in Emory, and then we started our 2 first classes. We've had ups and downs with our program. Basically, the first initial period of 36 months, we had 2 large classes and 2 smaller classes. We don't have any dedicated staff. All of our staff, even though we have quite a few lifestyle coaches trained, our staff all have other duties here also. But we did not meet the requirements for the first initial 36 months. We were stayed in pending. So we were advised through technical assistance through DTAC to resign from the program and re-enroll, which we did in early of 2018. Since then, we've had 2 classes that were successful, and we reached full recognition status in 2019. So we offer our classes in person now. We continue to use that mode of education because of can you all hear me?
Now.
Okay, my thing came up, said internet unstable, sorry. Anyway, we offer at MLK, and we also do worksite wellness programs. Our second class was at a residential facility, Holy Angels here in Shreveport, for their staff. Like I said, they were both big classes, the first 2 classes, but we did not meet all of the goals for the participants. And the makeup sessions for the in-person mode is pretty flexible, so we've been able to keep it as an in-person mode of delivery. We've had, over the lifetime of our program so far, 10 facilitators trained. 6 of them are still current with the program. Some of them are volunteers, some of them are contracts, some of them are staff. Our last cohort ended June 30th of 2020, and the last part of the program was during COVID, and we were able to be pretty flexible in making up the sessions. We do not, all of our services are free, so we do not bill Medicare, Medicaid, or a fee for participating in this program. A little bit of an overview of MLK program.
Thank you so much, Janet. Now we'll look at the benefits of diabetes prevention programming. So I'll start with Alexis. If you can tell us some of the major benefits you've seen with your program.
So the program allows our team members the opportunity to get healthy basically at their own pace. We explain to our participants that our program is an evidence-based lifestyle change that will help them reduce the risk of type 2 diabetes. We also explain that this is not a fad diet or a quick fix. This is a complete lifestyle change. And I feel like the most rewarding outcome for this first cohort, because we're just getting started, is listening each week to our team members' success stories. One week we had a team member tell us that she's never had so much support while trying to become healthy. She told us that she appreciated being able to contact her lifestyle coach throughout the week to answer questions that she had, and she really enjoys learning from the health coaches. Our team members really enjoy the interaction that they're getting with our lifestyle coaches. And I would just like to say our first cohort, we have 2 amazing lifestyle coaches that connect very well with our team members. So I think the benefit for us, our lifestyle coaches are actually health coaches in our health system. So they have a great connection with the team members. So I feel that that's where our success is coming from.
That's great. Thanks, Alexis. Cindy, can you give us a look at some of the benefits you've seen with your program?
Yeah, sure. Some of the things that help are the pre-diabetic patients at our clinic at MLK. It's good to be able to help them prevent or delay type 2 diabetes and improve their health. And it adds to the prevention and health education we already provide on the patient's level and also on the community level. We can bring awareness to our programs when our other providers, private physicians, our local hospitals, and other community organizations refer those patients to us. And it's also good to be a part of a nationwide program so that we're working all together. I think one of the biggest benefits that I see in 6 years that I've been doing this here at this clinic is just helping the patients recognize and giving them control of this. You know, when they see a problem, when they can identify it and correct it, it gives kind of them a sense of, like earlier Rebecca said, empowering the patients, and also a confidence too, that when they go to their doctor or they go to the hospital or they have other family members, hey, I learned this here, I want to share this with you, or ask the doctor, what do you think about my A1C? When they learn certain things and what it means, it's so important to that patient as a whole. So I see the participants being able to make changes in their lifestyle. They see results too. Our group had a difficult time this year with the COVID, and I'm still connecting with them on a maybe once a week basis, just sending them texts, just, you know, encouraging them to continue, because it was real difficult for them. But once they see that these changes are effective and how important it is, and they see the results, that's the joy that we get out of what we do here, and also for the patient.
Thank you, Cindy. So now we'll look at some of the barriers that have been seen in the programming. Alexis, if you'll get us started, can you tell me you consider your biggest barrier for your program as a whole, and also provide some tips or guidelines for overcoming or decreasing any of these barriers you've encountered?
Okay, so normally at the health system, we at Healthy Lives would set up health tables around the hospital and our business office to recruit for any programming that we might have. But due to COVID, we were not allowed to recruit that way. We only were able to send out emails. We had to get very creative by sending out like targeted emails to team members with prediabetes. Our health coaches had to send personal emails to their team members that they were actively coaching to promote the Stay Healthy program. Our initial challenge was to get the buy-in from our team members. Healthy Lives, we offer other programs to include weight management and a diabetes program. We had to explain that about our Stay Healthy program. Team members were initially thinking that we were saying that they had diabetes. So we had to explain what prediabetes was and the purpose of and the benefits of our Stay Healthy program. So some of our biggest barriers were initially participation. Our current population at FMLO team members, their work schedules changed. A lot of departments started working from home. We had to make suggestions to department heads about getting them to understand why this program was so important. Selling point for us was explaining how reducing prediabetes could increase work productivity. Engagement was another barrier that we faced, making sure The participants continue throughout the program. Our lifestyle coaches, we send out weekly emails and support tools and success stories from the CDC to keep our participants actively engaged. But we have to really work on the engagement piece. COVID was so unexpected challenge for us. We initially planned for in-person classes, and we wanted to do it at lunchtime. However, due to COVID, majority of our team members, like I stated before, started working from home, and those team members were not sure of the commitment that they would want to give us. We're still overcoming these barriers on a weekly basis. We tell the team members that we take everything by week case so that they don't become overwhelmed with the Stay Healthy program, because it is a one-year commitment, and that's a lot for a team member. So we want to just take it weekly.
Thank you, Alexis. That's some great information. Cindy, can you share some of your biggest barriers for your program and then some tips and guidelines for overcoming those?
Sure. Recruiting probably is one of the biggest challenges for a 12-month program. Making the patient realize, or helping them realize, that this is a commitment for a year. Keeping them motivated, especially after the first 6 months. Meeting all the course requirements for the cohort group. We had a little bit more challenges. Not having a buy-in from an outside partner like local gym or other businesses to help recruit our patient population that was interested in the class. And it's a lot of hard work, record keeping, especially for when you don't have a designated staff, like Janet said earlier. We all have other job duties here. So the record keeping is a big challenge for the program, but it's worth it. Some of the ways that we overcame the challenges we offer incentives to the people that participate. We do grocery tours, we give measuring cups, food scales, exercise, workout bands, pedometers. So, a lot of people like to have gifts given. We bring in guest speakers, not only just, we have a registered dietitian and we have registered nurses, but we do yoga instructors that come in. Sometimes we have other nurses that come in that specialize in diabetes education. We also try to do flexible in rescheduling our classes and makeup classes, especially with COVID. We've tried to do what we can to accommodate the patient or participant. I don't want to say patient. And also one of the things, we try not to make it be a competition, even though some of them will want to compete against their classmates. We try to make it as a group camaraderie and try to encourage them as a group. But I've seen so much bonding in these classes for the whole year through our groups that they encourage each other. When one of them's down, they'll encourage the other. And like Alexis says, we don't call it a diet class. We call it lifestyle changes, because that's really what it is. It's going to change your life. It's a lifestyle change in order for you to prevent diabetes from progressing or happening. One thing we try to do is get the class involved. It's not just one participant or me teaching the whole class. We like for them to get involved. So we do have activities where they are allowed to get involved and be part of the class. Instead of after the 6-month class, when your first 6 months is up and then your second 6 months begins, we like to meet every 2 weeks instead of once a month. Most of the time, the classes want to meet. They don't want to separate and go once a month, because it's enjoyable. It's an outing for them, and they like to come to the class. We use text, we use emails, we use phones. We're available for them. I do give the class participants my cell phone number, so they can text or call if they have a question that they don't want to ask in front of the other participants, or when we're not meeting. So the biggest thing is to not get discouraged as an instructor. because then once you are discouraged, then the class is discouraged. So, you know, it's great. It works good, and there are significant changes to these participants' life.
Thank you, Cindy. That was some great information. Now I want to talk a little about telehealth. Alexis, can you tell us if you've provided your diabetes prevention program through telehealth? And if so, give us some of the challenges and just any tips that you can give on how you've, addressed this.
Sure. So we presently do offer our program partially through like telehealth for our participants who don't feel comfortable being in person. Our biggest challenge was making sure that our lifestyle coaches were comfortable using this platform because we went from being on the phone or in person. I highly recommend lifestyle coaches get very familiar with the platform that you're going to use before you roll it out to your participants. I also suggest having a technology or computer IT person on the call to help minimize any technical issues. We were very lucky to get some of our participants in this first cohort. They're very technologically savvy, so they were able to help us out. So I do recommend having an IT person on the call if you're going to use telehealth. But the most exciting impact is the participants being comfortable in their own homes, and they start to open up to the lifestyle coaches. So it's like even though it might be a little hard to engage like on a web-based type situation, they do feel comfortable in their homes. They might not initially turn their cameras on, but they are in the comforts of their home, so they feel comfortable talking to you, and then they'll start opening up a little bit more with their participants. So this is what we've experienced with our DPP program.
Thank you, Alexis. That's some great information. Cindy, did you have anything to add to telehealth?
No, we don't do telehealth for the classes. We try to do in person as much as we can with social distancing, and we do phone contacts and texting.
Okay. All right. So I think both of you touched on this a little bit, but we'll go ahead and give you a chance to touch on any specific barriers you've encountered with your participants that maybe you didn't mention earlier. I think you've touched on a little bit of both, but is there anything else you can think of participant-wise that has been a challenge, and any tips on, improving that with your patients, your participants?
This is Alexis. I'll go first. So staying motivated throughout the program. This is a year commitment. Is a lot for most people. Our participants do express that this is a big commitment. Not only does the lifestyle coach send out weekly emails, our lifestyle coach, this cohort, she's been doing weekly challenges just to keep our participants engaged. Also, make sure you check with appointment time and location to make sure it's convenient for your participants. We did a poll with our group to make sure the time was convenient for all the participants. Even though a lot of them were working from home, they still had to go to work. So we wanted to make sure that the time that we offered was something that all the participants we could accommodate all of our participants. So the two things is keeping people motivated and making sure you have appointment times that's convenient for all your participants.
Thank you. Cindy, do you have anything to add to that? Any specific barriers that have been presented to your participants?
I just think what Alexis said, just to reiterate that, and just that contact with the patient or the participant after class, just to the weekly contact, or sending a quick text to them. How are you doing? Or challenge, like she said, this is what we're going to be studying or going over this week. It's just staying in touch with the group and letting them know that you're there for them and keeping them encouraged through the whole year.
Thank you. That sounds great. So this closes out our questions we have for our lifestyle coach panelists. I do want to break this up and go ahead and take questions from our participants regarding the diabetes prevention programming. And I see that we already have a question that's come in. I don't know if you can access that, Alexis, but it's specifically to you, and I can read it aloud. It says, can Alexa share some of the weekly challenges that they have done?
So we've done, oh, I'm sorry. So we've done step challenges, making sure they've gotten enough steps in. That was one of our challenges. And then another challenge was bringing in like different recipes, just a reminder. So those are the two that we've done so far. I'm pretty sure our lifestyle coach, I don't know if she's on here, Kathy, she comes up with a lot of challenges, but that has been the two that's been working very well for us.
They sound great. Thank you. Okay, so again, I'm opening it up for questions to our panelists from the participants. So you can go ahead and enter that in either the chat box or the Q&A box.
So I see a question coming in asking how we're overcoming the challenges with virtual learning. We're taking it by a weekly basis, honestly. I know one of the challenges was some of our participants didn't want to turn on their cameras. So the engagement part was a little rocky initially, but some of them are starting to turn on their cameras. So each week we kind of have like a huddle after the class, maybe the next day, to kind of figure out what we can do better for the next week. So honestly, with COVID and things changing so rapidly, you have to be flexible if you're going to use the virtual learning platform. And make sure that you understand that some people might not be comfortable using the virtual learning platforms. So understand that they might have some barriers to overcome just learning the technology.
Thank you. Okay, any other questions? We'll give it a second to see if any other questions come in. Okay, there is one. Do you see it, Alexis?
Yeah. So all of our team members,
Can I read it out loud just in case someone hasn't accessed it? It says, is anyone having challenges with elder people having challenges with virtual learning?
So all of our team members are employees. So if they are having some trouble, we haven't experienced too much trouble because we were fortunate enough to have an IT person in our first cohort. So that's why I really recommended having an IT person with your, if you're going to use the virtual platform. So no, I mean, I don't want to, like, our participants are all working age. So they're all working in the health system. So no, not really with the virtual learning platform. They just probably had to learn whatever system we were using. But
okay, another question. How did you all recruit participants for the program?
So we were able, this is Alexis, we were able to recruit because we actually do health coaching throughout the health system. So we were able to look at our data to see which one of our team members were actually pre-diabetic. So we targeted that population to recruit for our program.
At MLK, our first two classes, our first class was held at the center, and it included patients, family of staff, and some staff. And then our second one was a worksite wellness program at Holy Angels facility for staff. And what was successful about the initial class, even though we did not make full recognition that first 36 months, is that with the worksite wellness program, if the employer has buy-in with the program, they allowed the participants to come during their workday. Somebody just filled in their spot so that they did not have to come to at another time. They didn't have to miss lunch or anything. So the employer was very proactive with that group.
Okay, so have you had participants that started with the program and then dropped off after moving to virtual learning?
No, not for us. A lot of them were already virtual. We only probably had one person that wanted to be in person, so they were all comfortable being virtual. So no, we haven't had anyone drop off because it was virtual learning.
All right, I'll give us a few more seconds to close out. To take any more questions. See if anything comes in. And then
I want to also share before, it looks like we do have one more question I think that came up, but I wanted to share just to reiterate those two questions that you were speaking on, Alexis, around challenges for virtual learning, and then also reaching kind of that vulnerable population, people that maybe are not tech savvy or don't have access to those virtual platforms. A suggestion that was given, I can't remember exactly where it came from. It might have been one of the lifestyle coach entities that we were talking with, or one of our webinars that we did. They suggested, if possible, with all the restrictions and guidelines now, if you're able to maybe have a class come in person just to meet for the first time in person, to kind of build that camaraderie and that trust amongst all participants. And it doesn't maybe have to be the first session in that hour long. It could just really be something very informal. And then even at that informal meeting, to kind of build that trust and camaraderie amongst everyone, you could go through and over some of the virtual, the challenges that they may have, or maybe helping them set up if it's a Zoom app on their phone, or going through those things, if you can do that, obviously with trying to keep distance between everyone and everything like that. That's some ideas maybe to kind of help move forward with the challenges that come with virtual learning.
Thanks, Rebecca. We'll take one last question, which we have here. It says, have you had any issues with participants sending in their weekly weigh-in or activity?
We haven't had any. A lot of our participants work in our business office, so they're on their computers every day. So we didn't have a problem with them sending in their weights and activities to us.
Yeah, we didn't either, because they would send it to me by phone, or they never sent it by mail, or they'd call me.
Okay, that's what I was going to ask. What mode? Do they normally email
Emailed or text or call?
Text. Okay. So whatever is easiest for them to make sure they get it in.
Right.
Makes a difference. Okay, well, we'll close out the questions here. If anyone still has any questions after this, we'll give a chance to address those possibly at the end, or we can email those to be addressed. All right, now we're going to move on to our diabetes education panelists and focus some discussion on their own DSMES experience. So we'll get started. I'd like to get a program overview of your diabetes self-management education support program. Can you get us started, Lindsay, with an overview of your program?
Mid-City Clinic. It is on North Foster in the heart of Mid-City, Baton Rouge. Can y'all hear me?
Barely. Is there any way you can maybe increase the volume, or?
I already did. Let's try again. I'm sorry.
Okay.
Is that better? No.
Slightly.
I'm sorry about that.
Well, I can hear you, I guess.
Okay, I'll try to talk
as loud as you can.
All right, so I'm at the Our Lady of the Lake Mid-City Clinic on North Foster in the heart of Mid-City, Baton Rouge. We are an ambulatory outpatient clinic. We have family practice here. We have a primary clinic. We have pharmacy. We have a little bit of everything at our clinic, which is nice for our patients. Right now, we are mostly doing face-to-face visits, but some people, as we all know, are not comfortable with coming face-to-face, so we are doing telehealth visits when it's needed. Our particular program is American Diabetes Association accredited. We do see type 1s and type 2s. Our population tends to be a very vulnerable population. It's individuals that are in the North Baton Rouge Mid-City area, and we'll talk more about that, about some of the barriers that come from that. In our particular program, they see me, I'm one of the dietitians here, and our diabetes nurse as well. And then we used to, prior to the pandemic, have 3 classes that they attended, but our classroom is not big enough for us to social distance, so now we're having to do those individually. We do, like I said, have 2 educators here. We have myself, and we also have an RN certified diabetes educator as well.
All right, thank you, Lindsay. Candace, can you give us a little overview of your program at Lolly Kemp?
Yes, ma'am. Hey, I'm Candace. I'm one of the dietitians over at Lolly Kemp. At Lolly Kemp Medical Center, we are a charity hospital. So our clinic is both a clinic and the hospital. We have been certified by the American Diabetes Association for about 1 year. We cater to both type 1s and type 2s. We really don't deal with gestational diabetes here because we do not have an OB program at our facility. Most of our patients are about ages 40 to 60. And since COVID, we have the same problem as Lindsay. Our classroom is not big enough to accommodate social distancing. So instead of having these nice organized classes, now we've got just individual sessions kind of scattered everywhere throughout our schedule. Our team actually consists of 5 people. We have 3 RDs on our team. We have an RN and a social worker. And I'm also the CDCES now too on the program.
Thank you, Candace. Janet, can you give us an overview of the program at MLK?
Sure. Our program is called Living Well with Diabetes. We were certified through the American Diabetes Association in August of 2015. Our participants are type 1, type 2 diabetics. Our class basically are 4 1.5 to 2 hour sessions that cover the required materials. We also do individual classes, sessions, because our patients they're underinsured or uninsured. We try to do as much as we can within the patient visit. And there's some of our participants are not going to or cannot come back for a separate group class. So at that time, on those particular participants, we incorporate the program within their clinic visit. And we also supplement with video instruction that we produce ourselves at the center. Our current team is our 3 RNs and a dietitian. 2 of them are CDEs, and then we also bring in guest speakers like we do with our DPP program, and incorporate grocery store tours within the group too.
Great. Okay, now we're going to take a look at some of the benefits that your facilities have seen from programming. So we'll start with Lindsay. Can you tell us some of the major benefits that your program has provided?
Yes, of course. We're actually very proud. In our program, we have seen a decrease of an ANC by 2%. So you really get to see the benefits of helping the patients improve their health and understand their diabetes in the long term, which will then help prevent those complications. So that's really, it's one of the biggest things that we're proud of, but also it helps the patient, which I think all diabetes educators, that's what we want. We want to see those long-term results for our patients. Also, we have really good relationships with our referring providers here. If we see something that they might not see, we can always go to our providers and say, hey, this person needs this. And so developing those relationships to help the patients, I think, are some of the best benefits that we've seen.
That's great, Lindsay. Candace, can you speak to some of the benefits that your program provides?
Yeah, our program, we really try to focus on the patient as a whole. You know, it's one thing to say, oh, make sure you're taking your insulin every day, but it's another thing to say, do you have the money to get your insulin? Do you have transportation? And so we work through a lot of barriers like that with our patients. One thing that I have noticed since we have become certified, because we were teaching diabetes education before, but we weren't following the ADA curriculum. Since we have become certified and we're now doing the full ADA curriculum, it's brought to light some things that we were not teaching before we were accredited. Like now we have a social worker on our team. So it's given us that resource, you know, to where we can go more in depth with diabetes and depression and the whole psychosocial side of it. And that's a side that we were lacking before we became certified.
Oh, good. Thank you, Candace. Cindy, can you talk to some of the benefits you've seen with your program?
Sure. I think one of the biggest benefits is just to see the patient realize that they can make changes, that they can have control of this, and to treat, like one of the educators just said, the patient as a whole, and not just deal on one thing, but diabetes overall, because it affects every part of their body, not just whether their sugar's high or low. But when you can educate the patient and they understand and they get it, and then they can make a change, it's a rewarding thing for them, as well as also for the us as a provider, because one little thing that they make a change in will affect everything that they do. And the class offers many different areas of education, not just dealing with medicine, but dealing with the diet, the psych, the social support that they need from their family and from their provider. So yeah, we've been lucky with our providers to help and make changes for our patients and help in the educating that they need.
That sounds great. Thank you, Cindy. Now we'll move on to some of the barriers that you've encountered with your program. So we'll start with Lindsay. So what do you consider your biggest barrier for your program? And if you can give us any tips or guidelines for overcoming those.
I think one of our biggest barriers is actually getting our patients to their appointments, transportation, other appointments. Life gets like in between a lot of times. So we really try to help the patients either set up medical transportation, if we can get it when they're going to another appointment, if they don't have Medicare, we do try to do that. But getting the patients here, I think, is one of the biggest barriers, and then getting them to continue coming to see the nurse, see the dietitian, come to all the classes. It is a big commitment, not as big as the diabetes prevention program, but it's still a lot for any of our patients. The other educators did mention about making sure that they're affording their medicine, that they have all the tools to help them succeed, whether that's their medicine, whether that's the knowledge, whether that's the social support. I think as good educators in a good program, those are the things that we need to make sure we're doing to help them. But getting them here is probably the hardest barrier.
Yes. Cindy, Candace, can you add any barriers that you've seen with your program or with your participants?
Lindsay, I hate to keep mirroring your responses, but that is 100% our biggest barrier as well. Is, my car broke down yesterday, so sorry, I'm not coming. That has been one way that COVID has been a little bit of a blessing in disguise, is that it has opened us up more to the telemedicine side of it. You're not going to be able to make your appointment tomorrow? Okay, well, that's great, because guess what? I can call you instead, and we can do an over-the-phone consultation instead if you prefer. So that has helped our show rate some. Our other biggest barrier, honestly, is the lack of concern with a lot of our patients. Like, I got some sugar, but whatever, it's fine. It's just one Coke, or I only eat McDonald's every other day, so it's okay. That's also been a big barrier for us as well.
Okay, Cindy, can you tell us about any barriers you've seen with your program?
Probably just reiterate what the other two just said: transportation, and I think another thing is that the patient this time has to realize, like she just said, I just had a Coke, I just have a little touch of sugar. When we see type 1s and type 2s, and just to help them understand the difference and understand what this can do, one little Coke here and there, yeah, that may not be so bad. But when you do that every day, I think that just re-educating their thought process, because they've been told many times from other people that don't have diabetes or that have had, oh, that's not going to hurt you. Just reprogramming some of the things that they have learned before. That's kind of where, what my hardest part is.
Okay. So can I ask you all if, I think a recurring theme was transportation is a big barrier.
Mm-hmm.
Have you found any, I guess, ways around this or ways to improve this? Have you thought of any possibilities for improving this?
So, I'm sorry.
No, go ahead.
It's okay.
Go ahead.
We do try to, if they have Medicaid, we do try to set medical transportation for them for their next appointment while they're in our office, because then we're like, it's already set up. There's no ifs, ands, or buts. Also trying to give them enough notice in advance if they need to ask for a ride. We give them like a month's notice, like, okay, maybe this is an option. Those are what we try to do.
Mm-hmm.
And some other things that we do here as well is usually when a patient goes in to see the primary care provider, that primary care provider will set them up with a referral for a mammogram and for an eye exam and diabetes education. And so when we call the patient to schedule that appointment, we might, hey, you've got an eye exam on this day. While you're coming here anyway for this eye exam, can you see me as well? So we try to fit them into their other appointments to where it's less burden on the patient as well.
Okay. Yeah, those are good ideas.
Mm-hmm.
And any tips for overcoming some of the specific patient barriers, just improving their motivation or, engagement?
Well, give them an opportunity to ask questions. And one main thing is to not be judgmental. Some of it's cultural, some of it's just family, some of it's they just didn't know. They weren't ever told information that would be helpful. So just trying to be a motivator, not judging them, and not trying to change everything at once, but trying to fit things in that works for them and the rest of the family that's involved in their care.
That's great inputs. Does anyone have anything else to add with some great tips of, overcoming some of the barriers you've seen?
Nailed it all on the head. She put it all out.
Sounds good. Thank you. Okay, so I know the pandemic, COVID-19, has been a huge barrier for everyone in all that we do, but is there any, major barriers or even, like you said, a blessing in disguise? What is some of the, input that you have of how it's affected your program and how you've overcome it?
We've been using telehealth when it was in the beginning of the pandemic. We were using telehealth pretty much every appointment. We were calling the patients. We would call them multiple times if we had to. I think that was nice, but it's also, are they listening during their appointment? You have to make sure you're asking those teach back questions to make sure they're understanding, that they're not running to the bus stop to get their kid. You have to make sure they're paying attention. Also, sometimes it's hard to make sure a patient's understanding how to check their sugar or give their insulin over the phone when we had to do it over the phone. Also, just setting up the platform, whatever platform you're going to use for your visit, if it's going to be a video one, setting that up prior to the appointment, because if you don't, you're going to spend 30 minutes making sure that it's set up. It was nice to be, it's still nice to be able to communicate over the phone, but it's nice to have that visual aspect as well.
Yeah, I'm sorry, go ahead, Cindy.
Oh, Okay. Well, we just try to educate the patient when they're here in the clinic. Since we can't meet as a group, if they have an appointment, we'll take a little bit of extra time, take them aside and talk to them one-on-one and see what the problem is. We do have videos, like Janet said earlier, that we have a website that they can go to. Our dietitian has done those and they're excellent. So just staying in contact with the patient and getting what you can done when you can do it.
Great, that sounds great.
Zoom meetings are always great, but so many of our patients don't have that, cell phone service or the technology to even understand how to do a Zoom meeting. And so, but you know, we had the same problem where keeping a patient engaged over the phone for, you know, to really get in all the education that they need in that phone visit is really difficult. So that's why we do encourage our inpatient meetings. In-person meetings, sorry, not
So do any of you have any tips when we're relying on just virtual or even the telephone? Any tips for, you know, demonstration to the patient, or, you know, showing the patient, you know, specific things within the curriculum? You know, specifically, you know, something that would normally be a hands-on activity. How have you, you know, tackled this when it's been virtual or over the phone? Do you have any tips for that?
I personally, if I'm on the phone with them, and they're at home, I make them go to their kitchen and get a food label. And I'm like, tell them, if you're able to see it, tell me what you're reading. And it makes it fun because it's something they actually have in their kitchen. Just listening to what they're telling you, being as engaging as possible. If they're telling you, hey, it's giving me this error, well, what error is it telling you? What's happening? And trying to be as thorough with the questions helps.
Let me add something. One of the things that we do, and we've talked about it before, is that we produce our own videos here, and the people who are doing the videos, our dietitian and other people that are around here all the time, are familiar to the patients. So if we had to resort to a phone session, we could basically also do that and then tell them that we're going to email them or send them a video on a particular topic, and that's the person who is doing the video is somebody they're familiar with from being in the clinic. So that helps too.
Those are great ideas. Thank you, guys. Okay, so we're going to move on to our last topic, and that is if you can let us know if there are any other services that you offer or refer your participants to, you know, outside of the specific DSMES program.
We were having a monthly diabetes support group at Our Lady of the Lake Hospital. Since the pandemic, we haven't been doing that one as much. It was free for anybody who wanted to come. We also, at one of our clinics, offer a Go Get Healthy program. It's part of the Healthy BR with Mayor Sharon Weston Broom's initiative. It's for food insecure individuals. So if we have those patients who are unable to get the food that they need, it's a really cool resource. They have cooking classes with nutrition classes that I teach, and I do the grocery store tour. So that's another great aspect. If they're not even able to get the food that they need, that they can have or need, that it's another great resource. Also, here at our clinics, we have collaborative care where they do individual counseling with one of our social workers. So if we feel like that's what's needed, we can refer our patients to that as well.
Thank you, Lindsay. Candace, do you have anything to add to that?
Yeah, since the pandemic, you know, there was a diabetes classes that were in our area, but they've all been canceled since, like diabetes support programs, but those have all been canceled since the pandemic. Mostly what we have been referring to is food stamps, how to get food from the Council on Aging still, and how to go to the food banks as well. Most of our focus has been on food insecurity.
Thank you. Janet, do you have any services that you refer to?
Yeah, some of them are in-house also. We do have a care coordinator that works with any additional things and all that patients, participants may need that we can't provide here. But we have an on-site garden where we do vegetable distribution. We do the grocery store tours. We have healthy cooking demonstrations through guest chefs. Some of that has been put into our videos where they can still participate in that. We used to have a monthly exercise class here twice a month, but that has been suspended. We'll go back to that. And then the video education that we've been producing quite a few videos that's a good supplement. Our center is unique to where our patients come, they get everything in one visit. So they're here for their primary care visit, they get their diet, their medications, medication education, their lab work, everything at one time. And like Cindy mentioned before, trying to incorporate as much in that one visit is for high-risk patients is very important. So.
Thank you, Janet. Okay, so that ends our panel discussion on DSMES programming. So I really want to thank all of our panelists today. It really was some great information and just knowledge that you provided, and just, you know, insight and ideas that you have given our participants, you know, that they can apply to their own program. So thank you so much for being here and sharing that with us. What we'll do now is open it up to questions for our diabetes educator panelists. So if you will, just go ahead and type those in the Q&A box, and we'll leave a little time to take some questions. Okay. We have a question. It says, tell me how the garden program works.
This is Janet from MLK. Our garden is on site in our location. We've had it since 2014. We're fortunate that one of our pharmacy techs is also a master gardener, so she is in charge for maintaining that. But when patients are here at the clinic, they can harvest vegetables when they're in season. And also we have an outdoor pavilion where if the weather's nice, they've done diabetes education and DPP education outside, which really changes the environment. It takes you out of the clinical setting and puts you in a different environment. And I think the participants really appreciate that and get a lot out of it. So the dietitian can be out there and talk about a particular vegetable that we're growing, and the participants can see it actually growing. A lot of people have never seen that before. Our outside garden also has got a paved portion all around the pavilion, so any participant that is in a wheelchair or has a challenge walking with a walker can access the garden. And we also bring in other vegetables that we don't grow here to do vegetable distribution. During the summer, we distributed about 550 boxes of vegetables to every patient that came to the clinic, pharmacy or clinic patient.
That's awesome. Love that. Okay, we'll give time for some more questions. Thank you, Janet.
Hey, Marcy, I think there's a few other questions in the chat.
Yeah, just seeing those. Okay. Okay, we'll go ahead and ask this one because it goes along with the garden question. It says, where do the other vegetables come from? Can you answer that one, Janet?
Yes, we have a strong collaboration with Shreveport Green here in Shreveport. They operate a mobile market, and through some other grant funds that we were available to us, we collaborate with them they have a large garden too. They either grew the vegetables that we distribute to our patients, or through our grant program, they can go to their local farmers resources. They do all that legwork, and we purchase additional vegetables, and then they bring them over here and we distribute them to our patients.
Thank you. There's a question that says, are your participants only from your clinic or outside as well? And I'm guessing this is referring to the garden program.
Our patients for both programs, DSME and also for DPP, can be from within the clinic or from outside.
Okay. All right, we have a question. It says, as an OPH employee, how can we get to participate? Is this in regards to the garden program? Can you clarify that for me?
If it's in regards to the garden program, they can get in touch with me, and I can get them in contact with my garden coordinator who's on staff here. If it's something that they want to volunteer as part in the garden, they can just get in touch with me about it. I'm not sure exactly what they're referring to. So.
Okay, I think they followed up with that. Rebecca,
okay.
I think you can maybe answer this one. Do you see the question in the Q&A box?
Which question were you referring to?
It says, as an OPH employee, how can we get to participate in any of the diabetes programs?
Oh, okay. It's broken up into like 3 different questions. That's why I was wondering. So for OPH employees, I'm assuming they're asking for diabetes or DSMES resources to participate in.
Mm-hmm.
Any of the Well Ahead diabetes programs. We don't have any accredited DSMES programs within our bureau that we're teaching, so it's more of a referral. We did try to host a diabetes prevention pilot last year, and then it was interrupted with COVID. And at this time, I don't know when and if we will be able to start that program, since we're still not completely back in the office. But any other resources or programs, if you're looking, depending on where you live, there's other programs that we can definitely share that information with. And a lot of the diabetes prevention programs and the DSMES programs are on our community resource guide, which can be found on our Well Ahead website.
All right. Any other questions? I'll give it another few seconds to see if any questions come in. And we will give information on how to connect with us following the webinar. If you find that more questions pop up, you can definitely reach out to me, and I will direct those questions to any specific panelist that you have questions for. Okay, I don't see that any new questions are coming in. Oh wait, someone raised their hand. All right, let me see. Hold on, I had someone raise their hand, so I'll try to find them and unmute. I think they wanted to. Okay, is that Mandy? Mandy, are you able to? I think you should be unmuted. Okay, well, I think we may have lost her. But anyway, again, I will give information on how to connect with this. If you have any, questions following the close of the webinar, you can still connect with us to have those questions addressed. All right, so I've also included a list of links to some valuable resources that can assist in implementation and enhancement of your diabetes prevention or management programming. So here we have the CDC Customer Service for National Diabetes Prevention Program website. It can assist with information about prediabetes and diabetes prevention programs. The prediabetes risk test is really an easy and just excellent tool to get patients thinking about prediabetes and take action. The screening testing referral toolkit, this is for diabetes prevention and implementation. We also have the DSMES toolkit, which gives a comprehensive resource for achieving success with your DSMES program. I've also included links to these websites for the Association of Diabetes Care and Education Specialists and also the American Diabetes Association, because both of these organizations uphold the standards of care for diabetes. So you can find a wealth of diabetes related information on both of these websites. They're really great resources. So we will follow up this webinar with an email to all who would register, and it will include the list of these links, but also the presentation in its entirety and a link to today's recording. This presentation was recorded, so we will be sending that to all of you. Right, well, I really want to thank all the panelists again. It really was great to have you all here and just share all the information that you provided. It was very helpful and very valuable for I think us here at Wellhead and all our participants that we've had join us today. So thank you all for joining us, and please visit www.walpen.org to find out more information about our programs and resources, and also look out for our twice monthly newsletter with updates on trainings, resources, and other opportunities. Just thank you all for joining us today and for helping us move Louisiana's health forward. Have a great day.